Hello and good morning. Thank you for joining us this bright and early Thursday morning to get wiser about the WISeR model from CMS. Thank you for joining us, and just want to thank everyone who proactively submitted comments and questions in the registration button. Really appreciate that. Just from a housekeeping standpoint, we will have the chat disabled during the webinar today. If you have questions, however, please include them in the Q&A. So we will get going with a legal disclaimer, which I am required to, from our compliance department, put up regarding CPT and other things. But the agenda today will really focus on the wasteful and inappropriate service reduction model, otherwise known as WISeR. We will cover that and just provide an overview, really focusing on the nerve stem sector. There are other therapeutic areas affected or impacted, but we're going to focus today on the nerve stem piece. And we have some great panelists today. We have Rebecca Holley and Victoria Wallace, who are going to provide their perspectives from both a medical technology innovator perspective, whose technology is impacted by the model, as well as a legal and policy perspective. We're going to have a discussion with some questions and thoughts. And then the attendee Q&A, again, using your questions that you submitted proactively and the questions that we have come in during the session. So just from an introduction standpoint, I'm Tonya Dowd, Executive Vice President at PRIA Healthcare, where I lead reimbursement, market access, and corporate development. I have 25 years of experience in reimbursement policy, mainly focusing on the U.S. market. I lead our teams here at PRIA to help MedTech companies grow and achieve market adoption. And I also lead PRIA's efforts to grow organically through expansion of service offerings and inorganically through partnerships and scalable solutions. I've worked across multiple disease areas, bringing value-based pathways for new and novel technologies that drive adoption and long-term success. And I'm going to let Rebecca introduce herself, if you could, please.
Sure. Thanks, Tonya. Hi, everyone. My name is Rebecca Holley. I am the Director of Market Access and Reimbursement at Saluda Medical. About 10 years in the MedTech space, particularly focused within the startup world, delivering access and for the patient access and market access for new technologies and disruptive technologies to the MedTech landscape, focusing on making sure there's equitable, deliverable treatments to patients for these new and exciting technologies.
Thank you, Rebecca. We're so glad to have you. Victoria?
Hi, everybody. I'm Victoria Wallace. I'm a partner at the law firm Hogan, Lovells. I'm based out of Washington, D.C. I sit in our health group, and my practice focuses specifically on coding, coverage, and payment. So I work with companies from very early stage all the way through after you've gone to market and have commercialization, just ensuring that your patients and the providers who are purchasing your technologies have access to them.
Thank you, Victoria. Again, great to have you. I would be remiss if I didn't provide an overview of PRIA Healthcare Services as it relates to it in the context of the WISeR model. So at PRIA, we offer really strategic reimbursement consulting and market access services throughout the product lifecycle for the MedTech space, in particular, medical devices. So we do strategic commercial planning, market access planning, and reimbursement services, both strategic planning as well as execution of the reimbursement plan. We do evidence generation planning, health economics outcomes research, as well as clinical study planning for our clients' technologies. We have an advisory council that consists of subject matter experts in the healthcare ecosystem. These are individuals from formerly payer medical directors, value analysis committee executives, and other subject matter expertise. We also work with payers throughout the country to make sure that they have the most current and up-to-date clinical and health economic data for our clients' technologies. And we also have, finally, the patient access platform solutions service line, which I will go into in a little bit more detail here. So we have a patient access platform solutions service, and our access programs are structured around the AdvaMed guidelines and help patients overcome barriers to receiving care by facilitating access to medical technologies by assisting physicians in obtaining coverage decisions, positive decisions by payers. Our patient advocates are highly experienced and support patients by organizing, preparing, and submitting coverage determination requests, prior authorizations, pre-certifications, and appeals. And we support providers and their staff in documenting medically necessary care and effectively communicating with payers and programs such as with the WISeR model. We help our clients' customers understand payer policies and provide training on obtaining prior authorizations, including sample letters, medical necessity documentation, and appeals guidance. And really kind of at the core and central here is our patient access platform, which leverages technology platform through HIPAA-compliant portal to protect, of course, patient privacy and provide real-time access to very valuable market data and experience through our programs. Our track record is stellar, and again, this is focused on the nerve stimulation arena. But for Medicare Advantage cases in the impacted therapeutic areas, we see prior authorization success in the high 90s, program to program. We take the time to really understand the specific payer medical policies on a case-by-case basis and align that with medical necessity criteria. And we have helped over 40,000 patients across all of our programs gain access to new and novel treatments. So just going into the WISeR model and providing an overview. So in terms of the specific kind of fast facts, I think the headline is CMS is imposing prior authorization requirements within traditional Medicare, targeting high-cost, high-volume procedures prone to inappropriate use and which are covered under a current national coverage decision or a local coverage decision in specific states and MAC jurisdictions, which we'll go over in just a few minutes. CMS will use model participants, and these are companies and organizations that currently perform prior authorization checkpoints, essentially, for commercial health plans and commercial health plan members, including managed Medicare beneficiaries. And they're going to use AI. I think a presentation wouldn't be a presentation in 2025 if we didn't mention AI, but they are going to use AI and technology capabilities to conduct prior authorization and prepayment review processes to flag and expedite prior authorizations decisions. The model will launch in January 1st of 2026, so it's coming very quickly, and it will run through December 31st of 2031. The model targets wasteful care, quote unquote, with data-driven oversight and processes, and aims to foster evidence-based care and increase transparency of existing Medicare coverage policies. Again, those NCDs and LCDs and other criteria. In terms of the selected services, they're going to focus on specific therapeutic areas. Again, nerve stim being one of them, the focus of today's presentation, knee arthroscopy for knee osteoarthritis, and skin and tissue substitutes. Other services are listed here on the left-hand side, and excluded services will be inpatient-only procedures, emergency, or high-risk delay-sensitive services. In terms of the MAC jurisdictions, it will be selected and focused on specific jurisdictions. Medicare administrative contractors are those organizations and entities dispersed throughout the United States that administer the Medicare program on behalf of CMS. And the jurisdictions affected here are circled in red, and they are essentially within the Novitas, Noridian, and CGS Medicare MAC jurisdictions. The very specific states, again, that are going to be affected in this initial rollout are New Jersey, Ohio, Oklahoma, Texas, Arizona, and Washington. So again, it's a very, very finite state-specific focus as well as Medicare jurisdiction focus. But we will talk about whether or not we believe and the panelists believe if that's going to expand before the demonstration period is over or after. In terms of the coding and the policy, in terms of the NCDs and LCDs, looking at again, very specific to the nerve stem space, the NCDs that are affected are here on the left, and the procedures specifically that are included in those NCDs and LCDs are in the middle. So you can see the peripheral nerve stimulation, spinal cord stimulation, sacral nerve stimulation, deep brain stimulation, vagal nerve stimulation, and hypoglossal nerve stimulation, and then the corresponding CPT code. So our team did an analysis on procedures and CPT codes specifically that are going to be impacted by the initial NCD and LCD list that is published in the Federal Register. I think there's been a lot of questions around specifically for PNS and SCS. There is a national coverage decision that's very broad for these technologies, and there's also a local coverage decision with Noridian that's a little bit more specific. And we listed out the requirement here in terms of what the LCD requires versus what the NCD requires. And I think that the biggest question on the table for therapeutic areas and procedures that are affected by this LCD is, will the WISeR model follow the Noridian LCD or the more broader NCD? And from our experience here at PRIA, we have seen the managed Medicare plans actually following the LCD, specifically not the NCD. So being much more specific to the specific criteria here on the left versus having the broader. So it remains to be seen what they will do, but that's been our experience from past history. So I am going to move in now to our panelists and the perspectives from each of the panelists, and we will start off with Rebecca Holley from the MedTech Innovator perspective.
Yeah, thanks, Tonya. So from our perspective at Saluda Medical, we're a disruptive technology. I wouldn't say we're quite in the startup phase. We've done a lot of due diligence and we're commercialized. But, from a MedTech perspective, we always recognize that access equals adoption. So, for any MedTech, whether it's startup or, a large company with a product that's going to be affected here, lack of access or delay in access can always lead to reduced adoption or stickiness within certain accounts. And it's definitely a concern of how could WISeR potentially limit access to these data-supported, innovative, or disruptive therapies. So, for example, some of the questions we first had when we heard about the model were where we see an increase in denials for normally covered, accessible therapies. And I think the answer to that is inevitably yes. Most of these therapies did not previously require prior authorization in most sites of service. Therefore, we will inevitably see some additional denials there, which will slow down some access in certain areas. The prior authorization process is inherently very administrative and slows down patient access and kind of no matter what you do. So I do think we will see some delays there. And we may see a hesitancy for providers to adopt therapies on this list, despite the robust clinical evidence. The labeling of low-value care and fraud, waste, and abuse could be a deterrence to some providers who are just looking at these therapies for patients in their practice, especially from a startup perspective if it's a newer technology.
Yeah. Thank you, Rebecca. And Saluda has been such a proactive player here, and I really want to hear your perspective in terms of what you're doing right now to prepare your providers for this model.
Absolutely. So we have a really great partnership actually in PRIA Healthcare. Our Saluda Smart Access program is driven by PRIA Healthcare. So some of the things that we are doing right now proactively and kind of as soon as we heard about the model is developing sort of a tiger team, with the PRIA team who has, developed a team specific to WISeR. So monthly meetings to discuss any updates and what we're hearing from WISeR, any criteria changes or things that are going to affect the way our Saluda Smart Access program runs. That includes looking at our staffing plan very proactively. We expect to obviously see an influx in cases coming from these particular areas. as we encourage our providers to be very proactive and build that muscle memory right now of submitting all of their Medicare patients to our prior authorization program, regardless if they require prior authorization right now or not. We don't want it to be a shock to the system January 1st when all of a sudden all of their prior authorizations need to come through the program. We'd rather them start doing it now and get used to the process and what medical necessity criteria can be met. So that's one of the things we're doing. We're also creating, some external resources with the help of PRIA in order to, deliver medical necessity criteria, some check boxes for our providers so they know exactly what we're going to be looking for, but also utilizing our really high level objective data and to support our providers and protect their reimbursement as a disruptive technology. We want to make sure that while, WISeR can be seen as, in some cases, a liability, I think one of the best things you can do in MedTech and in a startup is look for opportunity and adversity, and that's what we're trying to do here at Saluda, leverage that really high-level data with the help of PRIA. We're sending out reminder emails through our program, so, hey, this is coming. We don't want, our providers, again, to get a shock January 1st if all of a sudden it's effective. So working with PRIA to send out some email blasts, which have been really effective for us in the past. And then, I think it's just leveraging our partnership with PRIA to the best of our ability. We have a really successful Smart Access program and using the data there to really deliver high-level results and protect our physicians' reimbursement. And we will continue to leverage that partnership as WISeR is effective to analyze any denials that are coming in, looking for buzzwords, trends, things of that nature, which the PRIA platform has been really successful in providing those data insights.
That's great. Thank you so much, Rebecca. Again, proactive partnership is the key here.
Absolutely.
Switching over to the legal and policy perspective, and we know that the WISeR model is not a proposed rule and not a proposed model. It is a model that will be implemented by the CMMI division of CMS. And Victoria, we've had some discussions, but we'd love to hear from your perspective, the legal and policy implications here.
Sure. Thanks, Tonya. Right. So I think as many noticed, there was something in the Federal Register, but it wasn't a proposed rule where comments were requested. And that is specifically because this is a Center for Medicare and Medicaid Innovation model. So in the Social Security Act, Section 1115A, which established CMMI, the Medicare, CMS has the authority to broadly waive certain requirements of the Social Security Act that might otherwise apply. One of those is the ability to waive notice and comment rulemaking. And so it is very typical that CMMI models do not go through notice and comment rulemaking. CMS staff put out what the model will be, and certainly I think CMS is always open to feedback, but it's sort of going to happen, right? Unless there's immense political pressure or something else to put a stop to it. In that line, there are other waiver authorities for CMMI models, which is how CMMI is able to do things within the context of a model that you might be scratching your heads and say, wait, but I thought Medicare couldn't do that, right? So one of those things at the bottom of the slide, we frequently say how prior authorization is very limited in the context of fee-for-service or traditional Medicare. There isn't explicit language in the Social Security Act that prohibits prior authorization, and in fact, for anybody on the line that maybe has a certain item of durable medical equipment or certain services that might be furnished in the hospital outpatient setting, there are limited instances in which Medicare does prior authorization in traditional fee-for-service Medicare outside the context of a model, but it is again very limited. And in the Federal Register notice for the WISeR model, CMS has this, it's one sentence, but I think the wording was very clever, that to the extent this, these two provisions that I have here, 1834 and 1869 of the Social Security Act, could be viewed as limiting our ability to do prior authorization, we are waiving those as well. So again, they're relying on that waiver authority that they've been given as part of the CMMI program. one of the other things to note is in that 1115A part of the statute, CMS can expand models if they are expected to reduce spending without reducing quality of care or improve or they're expected to improve quality of care without increasing spending. So, Tonya, I think you had teed this up a little bit, but do I think that the WISeR model will expand? Yes, I do. Whether that will be at year 3, where that, sort of first cut point is, I think likely something will happen then. But I wouldn't dismiss the possibility that there could be an expansion of the states that apply or an expansion of the policies that apply even prior to that 3-year point. And CMS has the authority to do that under the statute. Yeah. If I had a crystal ball and I was to say where I think this is going, I think that prior authorization for Medicare is going to happen on a much broader scale. And I would not be surprised if CMS uses data that comes out of the WISeR program to show, cost savings, which, you'll hear the word cost savings, but I really think what you'll hear is we prevented beneficiaries from having inappropriate, services provided. Mm-hmm. I think that could be used by the administration or by CMS generally to go to Congress and ask for a change in those 2 parts of the statute that are viewed as limiting Medicare's ability to do prior authorization, so that CMS won't have to do this as part of a model after 2031, but that it will just be a wholesale program that they and the MACs can implement.
Yeah, it's not business as usual, is it, Victoria?
No, it is not. It is not. And we can, go to the next slide. So yeah. I did just want to point out a few quirks that I'm sure other people have noticed about this model. So this is actually the first model where the model participants are not providers. So they are third parties that have AI and presumably some medical staff that can do that secondary review, but they don't otherwise have skin in the game, right? They're not on the hook if their claims start getting denied. And even the way that CMS set up the payment to the model participants, I think was an interesting choice. And in the town hall that CMS had hosted just a few weeks ago, they specifically said that, we decided not to do a flat fee for model participants or a per review payment, and instead we've tied it to cost savings with all of these safeguards in place. But when you really dig down into that, the model participants are incentivized to deny prior authorizations. I mean, that's what it is. And I think it's not a surprising choice, in my opinion, but, it is one that will have an impact on the providers who are the ones actually treating the patients, actually providing the services, and looking to get paid for those services. One final thought from me is CMS swears up and down in the materials that are on the special website they have for WISeR, in the town hall, everywhere, that this does not change coverage for these services, that these are not coverage determinations, it's not changing coverage. But in the town hall, there were some interesting statements about how the reason that these services were selected was because some of them are viewed as being low value, and or the current clinical literature suggests that they might not have widespread utility for patients or lead to great outcomes, etc. And my question back would be, well, if you're looking at current clinical evidence to decide what you're deeming to be low value, but there's a coverage policy in place, whether it's an NCD or an LCD, isn't that actually making a coverage determination, right? Shouldn't the real process be to update those coverage policies where you're following the processes that have been put in place to do the evidence review, get comments back on that, publish the proposed NCD or LCD, right? Like, that would be the process if you think items or services that have coverage currently, that the clinical evidence supporting that coverage has changed. So, and this is particularly, I think, a concern for older NCDs where the coverage itself, like what's in the policies themselves, it's very open-ended. And I'm not sure, and we'll have to see how AI is going to do a prior authorization when the coverage criteria themselves are very broad, without somehow narrowing what those criteria are. And to me, that's actually a coverage policy that's being made via the AI. So right. Just a few thoughts from me on the legal regulatory perspective side.
Yeah, no, these are great thoughts. And I think, it goes back to what I mentioned about the Noridian policy. It is a more restrictive coverage policy. And I do believe that they will use that versus the NCD, which is a lot more broad. But a lot of the NCDs, some of them are very old, and they don't take into account new technology. They don't take into account the data and the evidence that's been generated to support new technologies. What are your thoughts there? I mean, I think that's going to be very problematic. I think that CMS is going to get a lot of pushback on that.
Agree completely. And, several years ago, CMS had put into place this process to retire NCDs over 10 years old. I mean, we have some NCDs on the books that are pushing 30 years almost, right, before they've been looked at. And so, yeah, I mean, I worry that I don't know how AI is going to take a very old NCD that does apply to new technology just by virtue of how it was drafted, how they are going to take that and have AI somehow decide that, yes, this patient is eligible for coverage, or no, they're not. And to be fair, there's a lot of human error in prior authorization anyway, or claims review. I mean, there's no doubt about that. And, I know from my own clients that there can be, huge variability just from one reviewer to the next, right? And so that isn't great, and can certainly be improved. But at the same time, AI is only going to spit out what has been put into it from a back-end software perspective, and also from, then the inputs that they're receiving to apply that software to the new service. And where things are vague or broad or new technology technically fits, but there's nuance, I think that this is, the unfortunate reality is some patients are not going to receive services because providers are not going to want to take the risk, or providers are just going to have to be prepared that they're going to have to run these through the entire appeals process to get resolution.
Yeah. And if I'm not mistaken, there's the model participants will have an AI, so there's a robot, but there's also a human factor as well, right? So how do you think the human factor will play into the AI component under this model?
I think in a perfect world, from a provider, beneficiary, and manufacturer perspective, the human would take a critical look at the AI's decision to deny the prior authorization. I think in practice, what we are going to see is just rote approval of the denial. Similar to what we see in the appeals process now on post-claim review, right? Where a first-level denial happens, and it's not until you get to the ALJ that somebody actually takes a critical look at it. Yeah. Call me skeptical, but
yes, yeah. No, I agree. So I want to just kind of go to the broader panel discussion and ask some questions, specifically one for Rebecca. From a MedTech innovators perspective, there's a lot. Of course, the wording is inappropriate and wasteful technologies and services. What are your thoughts on that? I mean, again, given the fact that you've got an innovative product that's highly adopted, and you're included in this program. So how do you feel about that word?
Absolutely. Yeah, so I think that verbiage is very antiquated, and I think that the verbiage used is inappropriate given the level of evidence that have come out for these particular technologies, especially ours here at Saluda. You have technologies that are supported by robust clinical evidence, such as randomized control trials, that have been evolutions of existing technologies. For example, ours at making sure that we are utilizing proper patient selection through objective data. And so while I am frustrated at the terminology, again, I do see this as a level of an opportunity for a lot of us MedTech innovators, to prove CMS wrong in a way. And I would do that and encourage everyone to do your own data collection through this process, such as WISeR is doing. It's going to be important to, collect data on the prior authorizations that are going through, how many are being overturned, how many are being denied, taking a look at those trends, and opening a line of communication directly to CMS. So this is going to require a dual approach here, as we do with market access, of a top-down, bottom-up, and leveraging our data collection at the bottom to show that our patients are meeting medical necessity, and that this technology should not be labeled as fraud, waste, and abuse. But overall, yes, I think it's a very antiquated label. It's inappropriate for the technologies that I've listed, as many of them on there, including ours, are supported by high-level objective data, and they are benefiting patients around the globe on a daily basis to lead better lives.
Yeah, absolutely. Any thoughts, Victoria, from your perspective on that as well?
Yeah, I agree. And I think this goes to the point I made before, that if something is inappropriate or wasteful, that maybe the coverage policies need to change. Now, don't put it on me. I'm not asking CMS to change all these NCDs or LCDs, but, it seems like if the issue is that the NCD or the LCD doesn't account for, more modern day clinical literature. And that's not the case for all of the NCDs and LCDs chosen, right? I mean, skin substitutes are included, and they're going to have a brand new LCD effective January 1, right? So it's not for everything, but, certainly I think that, it's an overly broad characterization of the services that have been included here.
Mm-hmm. Yeah, I agree. Just kind of turning to, there are, essentially 3 ways providers and suppliers can participate. Either submitting the prior authorization request directly to the model participant, i.e. the AI plus human factor organization, submit the PA request directly to the MAC, and the MAC then forwards that to the model participant, or the provider and supplier can opt out and not submit a PA at all, and the claim will be subject to prior authorization and payment review post-care. Just maybe turning to Rebecca, from your provider standpoint, do you know what they're thinking in terms of what pathway they want to go down for EVO?
I think our providers are waiting on us, to understand what we believe is the best pathway. Thankful to have developed some good relationships with a lot of our providers and our key opinion leaders, and they would trust our recommendations. And I think the recommendation that we're going to be providing, first of all, is that proactive approach. So getting our providers to start, submitting the cases to our prior authorization team now, and ensuring that they do go through the prior authorization process versus the claims review. The claims review, while it may expedite the patient receiving the therapy up front, could pose a lot of issues post-service. And once the service is done, it's already done. We want to make sure that not only are patients receiving therapy, but that our providers and the therapy is protected. And so our recommendation to our providers is going to be to go the prior authorization route, meet medical necessity, and make sure you have, your patients meet medical necessity. And then our recommendation would be to continue to forward the prior authorizations to the MAC. We don't want to make this more complicated than CMS has already made it for our providers. And so, with our team here at PRIA, we want to make sure that we streamline everything. Everything is as simple as possible for all of our providers and for any providers out there. So I think through creating that muscle memory and keeping the process simple and easy of go through your prior authorization process as usual, we're submitting them to the same place, we're following up on the authorization to the same place. It's going to alleviate a lot of headaches and a lot of issues, and that potential for post-procedure reimbursement issues.
Yeah, that's great. Thank you. Just for you both, this is CMS is touting this as a voluntary program, but really it's a mandatory program for providers in the affected states and with the, affected procedures. And there's a carrot, right, for the gold carding program, which, remains to be seen how that's really going to be rolled out. But maybe from both of your perspectives, is this really, is it voluntary? Is it mandatory? Is it a little bit of both? I think there's a little confusion out there in the industry on those terms.
It's voluntary whether you submit the prior authorization, but there's going to be a medical review that happens, right? So it's voluntary if you don't want to take on risk. It's effectively involuntary, right? The only choice is you do prior authorization and you know ahead of time, okay, yes, this is going to be covered if I do the service. No prior authorization has been denied. I'm going to ABN the patient, and if they want to move forward, right, there's sort of a risk decision that's been made ahead of time. Or it's that I'm not doing prior authorization, and before I get paid, but after I've done the service, somebody is going to be doing a medical review anyway.
Yeah.
So, sure, it's voluntary if you want to have the AI review, but in essence, every single one of these services is going to be subject to a prepayment review.
Yeah, agreed. Any thoughts from your standpoint, Rebecca, on that?
Yeah, so I agree with everything Victoria said. It's the most voluntary program I've seen, so that's how I would describe it. While it is voluntary, maybe that verbiage could be confusing for some providers and for a lot of participants. I would personally put in our minds that it is involuntary and just prepare to, submit the prior authorizations up front.
Yeah, absolutely. I do see some hands raised from the audience, just to let the participants know, again, if you have a question or a thought, please include it in the Q&A, not the chat, but in the Q&A section of the presentation. We did receive some great questions from Proactively before the webinar today, and one was a great one. It was around, do we think that the impact will be greater for startups versus large MedTech? And I think there are implications for both. Would love to hear the panel's perspective on that.
Yeah, I can start. Again, I don't think we're quite at the startup phase here at Saluda. We've moved past that, where I think we're in between startup and large company size. And I will say, I think for both, it can impose, equal opportunity and equal problems as well. Maybe from a smaller startup perspective, there's an infrastructure concern there with the amount of prior authorizations that could potentially be coming to them for if they have an internal program or if they're using a vendor. Typically, through prior authorization programs, we see mainly the commercial patients coming for prior authorization, as those are the ones that require authorization and typically are a little bit harder to get approved. So now that we will also see the Medicare patients coming through the program, we would expect that there would need to be some additional infrastructure and therefore some additional investment on the prior authorization side. From a larger company perspective, just speaking from prior authorization, a lot of times they have a lot of different products that they're managing, and it can be hard to pay attention to a particular product that might be on this list. And it's going to be incredibly important to have a high level of scrutiny on any of your products that are affected. And your providers are going to need a lot of support and making sure that the patients meet medical necessity prior to helping with appeals, things of that nature. And so if you have case managers who have their attention diverted to multiple products, we may see some lower levels of approvals. That could potentially be an issue. However, on both sides, again, it does pose a huge opportunity to leverage some of your data at a higher level, at the top level with CMS, for both sides as well, to potentially show from a value-based care standpoint of why you should not be included on this list.
Yeah, and I would just add, Tonya, that I think for startups, you have more control over your customer. You don't have control over your customers, but you have control over hand-holding a little bit and providing information. And so you can sort of build structures earlier on that are around, these are the appropriate patients for this, device. Here are the Medicare coverage criteria. How can we help you build in checklists to ensure, that only the appropriate patients are getting this? And I think that's something that some startups are used to doing now anyway. I think there's just going to need to be some heightened awareness that is going to be a cost of doing business, even initially.
Exactly. Yeah. And the implications on continued evidence generation to support the value of technologies will inherently be affected here, as we move forward. A couple of questions. So we did have a question come in, and I'm going to read it verbatim. If there are LCDs or NCDs in effect on dates of service after January 1st, 2026 that are not specifically listed in the Federal Register notice, in other words, the Federal Register notice is incomplete or out of date, will the WISeR model adhere to the LCDs/NCDs actually in effect on January 1st, 2026, or are those included in the Federal Register?
I don't think we know the answer to that yet. That would be a great question to send to the WISeR email box that CMS has, or to pose, ahead of the next town hall that they have. I don't think we know. I do not expect that for new NCDs or LCDs that are, within scope, let's say, of what has currently been put out there for the model, I don't think they're going to issue Federal Register notices to update every single time. I think there might just be guidance that goes out.
Yeah. Okay. Any thoughts from your standpoint, Rebecca, on that one?
Yeah, I agree. I think there's so many unknowns, such as that question. I would definitely encourage everyone to reach out again to the WISeR help desk. They have been responsive to questions that I've asked, after the office hours when things were unclear. So any complex questions like that where we just haven't received the answers yet, they have been very responsive, surprisingly. So I would encourage people to reach out there.
Yeah. Do we have any thoughts, maybe this is a question for Victoria, on the potential players who will be the model participants and the number of model participants that CMS will choose?
Yeah, so I personally think that some of the participants were predetermined. So a la TSET, I think that CMS may have been running like a model of the model ahead of time, right, to see how it might work. So I would not be surprised to see some of the Medicare Advantage plans, not the plans themselves, but the companies that run them become model participants. I also would not be surprised to see some of the MACs or the companies that they roll up to, like Elevance, become some of those model participants. Because they already have the infrastructure, both with the AI as well as with the medical reviewers. They'll be able to show familiarity with the NCDs and the LCDs, et cetera. And just given the extremely short turnaround here, I mean, this was put out in June, and they had to submit an application 30 days later, and everything has to be up and running by January, right? Yeah. So the software, everything has to be up and running. To me, that suggests that they already had some people in mind who have already been doing this.
Yeah, exactly. And they'll be announced in the fall, which... Yes. There's no exact date, but my understanding is the fall. So we'll be waiting with bated breath to see who those are. Maybe a little bit of a provocative question for you both on that note. The administration has requested that the health plans in the U.S. make a pledge to reduce the number of prior authorizations. And then, kind of on the same token, about a week later, the WISeR model was announced. Was that coincidental, or is that intentional? I don't know if you guys have thoughts on that.
I will say it's ironic for sure. I don't know if it's coincidental or not, But I think at the same hand, where they're reducing prior authorization for some of the codes you see listed on Unite Healthcare or Aetna or Cigna, for example, that they're getting rid of prior authorization. They're typically codes that are not high value procedures who are, getting approved right off the bat regardless. So, it's almost a wash of removing those codes from prior authorization. At the same hand, they've made their value for eliminating fraud, waste, and abuse, their stance on that very, very strong. So I could see why, on one hand, they are reducing prior authorization for some services, and potentially the commercial insurance companies are doing that with some codes that are already getting approved. But at the same token, they're doing this due diligence to eliminate what they believe is fraud, waste, and abuse. So definitely ironic for sure. Again, I agree with Victoria. There probably was another way to accomplish these items, but it is add a little bit of humor to it.
Yeah, that's what I initially thought as well. Any thoughts, Victoria? You look like you're going to say something.
I agree completely. I agree. And, I agree.
Okay. We'll leave it at that. Just another question that came in specifically from the audience. Is authorization necessary for a New Jersey doctor who crosses state lines and performs procedures in New York or Pennsylvania?
It will be driven by the MAC that processes the claim. So, if the doctor is required to submit the claim to the Pennsylvania MAC, then it will apply, right? That's what's going to be the driver.
Mm-hmm. Okay. Yep. That's what I thought as well. And then there was just another question around the NCD 160.7 does not include overly specific criteria for authorizations for PNS that we talked about earlier. Would states outside of the Noridian jurisdiction, in this case, be able to apply the more specific criteria included for PNS in the Noridian LCD? And my thought would be the answer would be yes, but would love to hear your thoughts.
Yeah, I would agree. And one of the questions I had asked the WISeR team was specifically surrounding the criteria as well, someone who falls under 160.7, given that it is so vague. And they did state they will release criteria within the next few months and the applicable CPT codes, which I'm really looking forward to. I would proactively prepare yourselves to use more stringent criteria that's available through LCDs versus the vague LCD. It's better to be safe than sorry. So prepare your providers for that. Stricter criteria would be my recommendation. And prepare that that's probably going to include some of the buzzwords that are being utilized to train this AI prior authorization reviewing platform on what to look for. It's going to be good for your providers to understand, whereas maybe the NCD calls out just conservative treatment, what the buzzword is going to be that's going to trigger an approval versus, a flag and then moved on to the human review. So I would start looking closely at the more stringent criteria versus the broad NCD.
Yeah, I agree with that.
Just add, though, that would be a great example of this actually is creating coverage policies and it actually is changing coverage. Because if there's an NCD and one MAC has an LCD and another doesn't, like technically they can't borrow each other's LCDs or lack thereof, right? So, and the same would actually be true of the Medicare Advantage plans to some extent. So, I would just say, well, if the AI is adopting the more restrictive coverage policies from one jurisdiction that did not apply prior to this program, I think that's pretty decent evidence that it is actually creating coverage, making coverage decisions and changing them.
Yeah, agreed. We have some other additional questions come in. This is a great one. Some technologies are used in an off-label manner. How will this factor into AI-based authorization?
That is a good one.
Yeah.
I think there's a denial. I see a denial.
Potentially. I mean, physicians can use devices off-label, right? I mean, companies can't promote it, but physicians can choose to use off-label. I think the question is, will the AI be digging into the clinical evidence for that specific device. I mean, you'd also have to assume that the device is identified on the claim, on the prior authorization documentation, or is required to be identified, right? Because if it's not, that may not be known. So I think this is the big lawyer answer of it depends, and, TBD, more to be seen.
Yeah, exactly. Another question about the human factor. So going back to my comment about the AI robot plus the human factor, the human factor is traditionally in prior authorizations by regulations, all prior authorization denials need to be signed off by a medical director. So yes, absolutely, it's not a new thing. So a person needs to validate the AI robot decision. They are keeping that process flow in place for WISeR. So yes, that's what I would agree. They are kind of using that same process flow.
Except it's only for denials. So it's only,
okay.
So if the prior auth approves the service, the way I had understood the notice is there wouldn't be a human review there. It's only if it's denied.
Yeah, I think you're right on that one. And there was a question about mentioning the skin substitutes being a part of this. They absolutely are. And they are mentioned actually in the Federal Register notice. We are actually going to talk about skin substitutes in a future subsequent webinar. So please tune in and stay tuned on that one, because there's a lot happening in that space, not just with WISeR, but outside of it. So definitely a lot of movement there. I want to ask Victoria to take out her crystal ball and talk about her thoughts on additional therapeutic areas that will be required in the future, or may be required, and procedures. Do you have any thoughts of where they may go with this?
That is a phenomenal question. I would focus on recent OIG reports of fraud and abuse. I would say if something has been called out there, I'm not saying it's going to be RPM, but that could be something that happens, right? There's no coverage policies yet, right? But if CMS is viewing this as a tool for fraud and abuse, we know that RPM has been a hot topic. DME continues to be a hot topic, right? So I would actually look at, recent and forthcoming OIG reports, to see what the next therapeutic areas might be.
Yeah, I agree. That's a good place to start for sure, unfortunately. Any other parting? We've got about 8 minutes left. Any other parting thoughts, Rebecca, from your end, or Victoria, from your perspective, that you would advise and give to the audience for preparation?
Yeah, I would just say prepare. That would be my biggest words of advice, would be to prepare, be very proactive for implementation of this model. The companies that are going to be successful in the therapeutic areas that are going to be successful are the ones that support their field and their physicians at a white glove level is how I would describe it. This is confusing for patients, for providers, I think, and for some companies as well. And the best thing we can do is arm them and prepare them for this prior authorization requirement, and make sure that we're partnering with, our regional key opinion leaders, our high-level key opinion leaders, the societies, have a constant feedback loop of communication on how things are going, any issues that we're seeing. Are we seeing an increase of denials for patients who meet medical necessity, things of that nature, and just really overall prepare. We don't want to be caught January 1st and have our providers, our patients, or our field teams, specifically for MedTech, be left with their hands up and saying, what do I do? Where do I go? Use your partners, leverage, your resources like we have at PRIA, and just prepare.
Agreed. Victoria?
Yeah, and I would just add that I think the first few months are going to be rocky. Right? There's going to be a lot of learning that happens. And, to Rebecca's point about, there's always opportunity. I think the first few months will be a really big opportunity. Learn what, the this process does deem to be covered, but in the context of your applicable coverage policy and what doesn't. Every opportunity that there is to speak to the MAC or to the model participants and to learn from them and to provide them feedback, you should probably take it, right? So just, initially there might be some fits and starts. There's going to be things that don't go so great. Maybe some things do, but everything can be used to perfect it going forward.
Yeah, I agree. Okay. And of course, if you have specific questions and areas where PRIA can be of assistance, please don't hesitate to reach out to us. We are taking a very proactive approach as indicated by holding this webinar. We're taking a very proactive approach working with our clients, as Rebecca has indicated, and working with Victoria and her team to really stay on top of the policy changes. And of course, from an operational standpoint, making sure that our interfaces will be able to interface with the model participants, which we believe they will, because we are interfacing with them already. So we invite you to, again, ask additional questions. Please keep in touch and look forward to future webinars, specifically the skin substitute, as we move forward. And this model evolves. Thanks, everyone, for your participation. Rebecca, thank you so much for participating. Victoria, thank you so much. This is really a great conversation. So hopefully everybody got a lot out of it. Have a great rest of your day. Thanks, everyone.